இவங்க ரெண்டு பேரும் காலர் மைக் ஒரு காலர் ரெண்டு இல்லையா?
Hello.
You keep the caller mic. You give the hand mic.
We are starting, sir.
Hand mic. Shall we start?
Check, please. Hello.
Hello. Hello.
Rahul, come to the first floor. Rahul, come to the first floor. Kaviteja, come forward. Go back, I'll ask more questions.
Hello. Hello.
Good afternoon.
Hello.
Welcome to the webcast of the PG clinics under the Indian Academy of Pediatrics. Last time we had Professor Shankar Narayanan having a wonderful session. This time there will be a case discussion of a cardiovascular system case. This will be presented by Dr. Shruti, and the discussions will be me and Dr. Jnana Sambandam, Professor of Pediatric Cardiology, our hospital, and also the Institute of Child Health. This webcast is possible because of the support given by OCOT vaccines. This was discontinued for some time. We have restarted. Last 1 month it is going on very successfully. Let's hope we'll have a very good discussion on this. Over to Dr. Shruti.
Good afternoon, sir. This is Venkatesh, a 10-year-old boy hailing from Kanchipuram. The informant of the case, clinical history, is his mother, and the history is reliable. Venkatesh is a known case of heart disease, now presenting with increased exertional dyspnea for the past 2 months, and complains of right knee joint pain while walking for the past 2 months. We go on to the detailed history. Venkatesh is a developmentally normal child who first presented 2 years back with complaints of increased pulsations over the chest wall, which was felt by the mother while picking him up. At that point of time, he had no history of chest pain, no history of any respiratory distress, no history of any palpitations or increased feeling of his own heart pulsations. There was no history of any preceding sore throat, no history of associated rash, joint pain or any joint swelling or involuntary movements, no history of any painful nodules on the palm or any history of prolonged fever, no history of any epistaxis or abdominal pain. He has no history of any similar complaints in the past, no history of any complaints suggestive of a congenital onset like bluish discoloration of lips or extremities.
Shruti, sorry for stopping you.
Yes.
What is the primary symptom? You said so many, no history.
So his parents say that he has a heart problem. Presenting with complaints.
What symptom was the first symptom that you said the parents noticed?
Increased pulsations over the chest.
Increased pulsations.
Which is noted only by the mother when she was picking up the child.
When was that noticed?
2 years back.
2 years back. Where is it? He's a 10-year-old, isn't it?
Yes.
8-year-old. Where is the question of an 8-year-old boy being picked up and is it likely for that an 8-year-old boy is picked up by the mother?
10 years is only 20 kilos, so getting it, he's really...
Even that, how often does a mother carry a 8-year-old child and identify pulsations.
She very clearly gives the history of saying, when I was planning, I was trying to pick him up from the bed, I felt his pulsation. A very clear history like that.
Where was the pulsation felt?
She felt it over the chest, on the left side.
Left side, lower, upper, middle?
She doesn't feel like that.
Is it important?
Depending on the area.
Is it important to know where the pulsations were perceived by the mother? And if so, how and why?
So precordial pulsations as such could have been a parasternal heave or otherwise can be...
No, what are the situations in which a mother perceives pulsations in the left side of the chest? Or for that matter, what are the situations in which a mother perceives pulsations in the chest by and large? Can you tell me a few situations where a mother perceives pulsations in the chest wall of any child?
The tachycardia can be due to fever, can be anyhow high output.
The commonest is tachycardia, isn't it?
Yes.
Commonest is
Tachycardia.
when the heart is racing, always it is felt as abnormal by the mother. That is the commonest. Is this tachycardia in this child? So how do you know the pulsation that is perceived is tachycardia?
Any associated complaints like fever or...
Anybody from the audience? The mother will say it is beating fast, and she will say that it is a prominent pulsation. Isn't it? That is tachycardia. She will tell you it is racing. That is one. What are the other conditions in which you get prominent pulsations in the chest wall, other than tachycardia?
Cardiomyopathy.
Anybody? Yes, Sangeeta. I hope your heart doesn't beat faster on the question. Malnourished? Is it very common, a malnourished child? Can you give an example of
Anemia.
Commonest, if you have a child with anemia, definitely there will be a hypodynamic circulatory state. The pulsations may be more prominent. 2, 3.
Hypothyroidism.
Pardon? Anything, yeah, A, B, C, D, right? Anemia, beriberi, thyrotoxicosis, coarctation, etc., right? Then?
Any cardiomyopathy?
Okay, cardiomyopathy.
Any arrhythmias?
Arrhythmias, yes. And they, again, tachyarrhythmias to be specific. Anywhere else?
Right ventricular hypertrophy, parasternal heave.
Yeah, your parasternal heave can be felt to be a pulsation by the mother as abnormal, quite rightly. Anything else? Yeah, cardiomyopathy, cardiac failure, right? Anywhere else? Aneurysms, very uncommon in pediatric age group, but however it has to be kept in mind. Anything else?
Increased collateral.
Pardon?
Increased intercostal collateral.
Anything else? So, okay, the heart is normal but pulsations are abnormally felt by the mother. Heart is normal but the pulsations are felt abnormally by the mother. In other words, heart is functionally normal. If a child has got a dextrocardia, the mother might even give you a clue, I am feeling the pulsations on the right side, but otherwise my child is okay. Yes or no? She will give you the diagnosis if you take history. Right? Sometimes, if you have very severe chest deformities, I am doing something. Can you get the clue for that?
Scoliosis.
Yeah, when there is kyphoscoliosis, what will happen to the apex? It will be pushed forward, isn't it? Push forward, sometimes laterally or sometimes medially, and any child with a chest deformity may be perceived to have abnormal pulsations. Yes or no? Right. Anything else? Outside the heart, we mentioned something in the lung. Anywhere down? Sometimes a child with a
Hernia.
hepatomegaly, for example, a tricuspid regurgitation, or massive right ventricular hypertrophy, mother might perceive there is a pulsation in the epigastric region. Of course, rarely when you talk about aneurysm, it's aneurysm with the abdominal aorta. Here it is in the neck. And sometimes even the Corrigan sign. What is Corrigan sign?
Dancing carotid.
Dancing carotid may be perceived as pulsation by the mother.
Sometimes pulsations.
These are all situations where a mother might feel that there are abnormal pulsations. So when Shruti said pulsations, she must be more clear what she is meaning. What is your interpretation of the pulsations mentioned by the mother? Which of the discussed possibilities is the cause for the pulsations in this child?
So it was increased precordial pulsations. Increased pulsations felt on the left side of the chest.
Yeah. So which of the causes is responsible in this child? You said so many negative things.
Yeah, I could have probably said no pallor noted. He had fever at that point of time. Could have been tachycardia because of fever. But otherwise, thyrotoxicosis I have not ruled out. I directly went into thinking because it's in the left side chest, it must have been a probable underlying cardiac condition.
Okay. So you think it is due to here in this child, you think it's due to a
probable
cardiomegaly. What do you think is caused? Sometimes even a pulmonary hypertension, the mother may perceive pulsations exactly in the second space. So you must have gone into depth about what the pulsations are. Instead of saying, I mean, not that I am criticizing you, you are mentioning so many negative things. The first statement she made was pulsation. After that it is all
negative.
I think you should avoid doing that in the presentation. What will happen? If you do like that, the entire first statement will get diluted. You get my point?
Yes.
Instead of that, you qualify that statement. What was that? What is that?
So,
in fact,
she presented he first presented 2 years back with complaints of increased chest pulsations noted on the left side of the chest by his mother when he was trying to pick her up. But she says immediately she went to the doctor for it to be evaluated and was told that there is a disease of the heart valve, in the mother's words.
Okay. Always reserve the mother's concept and the diagnosis made at the end of your presentation. Otherwise you will be wrongly biased towards a wrong diagnosis. Right? Fine. Go ahead.
I went on to say that there is no history suggestive of any other
Nothing else is there. You mentioned so many negative things. Okay.
No history suggestive of any congestive cardiac failure, no history suggestive of any infective endocarditis. I tried to rule out any other major or minor criteria involved in probable rheumatic heart disease, rheumatic fever, and I went on to rule out if there is any previous history of congenital heart disease. For the above complaints, she was evaluated and found to have a valvular
problem. Was there any difficulty in breathing, shortness of breath?
She does not. She very clearly says 2 years back had no complaints of dyspnea.
Yeah.
But dyspnea
how can you take it? Like, is it you need to reassess or?
We need to reassess because something
it's very unlikely to have just
yes.
abnormal pulsation without any other cardiac complaints
problems.
In a cardiac case.
But even on repeated asking, she says no dyspnea. Even on exertion, his dyspnea complaints start only 10 months back.
Just to clarify, I think suddenly I thought of, I just wrote down, sometimes in any cardiac symptom, a mnemonic which my old teacher used to say becomes very useful. For example, the mnemonic is chloride. CLORIDE. It's very simple. Don't write down. You just understand. Since it struck me, because she omitted that, I'm just trying to stress that. One is the character. When you say pulsation, the character will also give you a diagnosis. For example, whether it is a parasternal heave or whether it is a pulmonary artery pulsation, the type of pulsation will give you if it is lifting, you know it's a right ventricular hypertrophy. If it's only a pulsation, you know it's a arterial pulsation. So character. Second is the location. Location means whether it is left, right, center, up, lower, down, second space, fourth space, or in the apex. Sometimes you may even get a pulsation in the apex. It may tell you a clue that it is a hyperdynamic apical impulse. Location. Third is the onset. How is the onset important? It tells you whether it is acute or chronic. Shruti, she noticed it insidiously or insidious. Fourth is radiation. Whatever that is happening, of course in a pulsation you are not going to say radiation, you are not going to see a wavy thing, but sometimes even that could become important if the pulsation in the neck is seen which is going up. Right? And then I is intensity, any symptom. It holds good for any cardiac symptom. Intensity, severity of chest pain, severity of dyspnea. D is duration, how long it is there. And E is exacerbating or alleviating factors. So I think this mnemonic is very, very useful when you inquire into any cardiac symptomatology. Chloride, no H, CLO-RIDE. Very, very useful. You can apply this to any cardiac symptom that the child has.
And also when you have an onset, you also have an offset. Arrhythmia will be a rapid offset, whereas a CCF symptoms will be gradual and offset. So when you have a gradual onset and a gradual offset, it's going to be more of a CCF or other reasons. If it's going to be arrhythmia, it's going to be rapid onset, rapid offset.
For the above complaints, he was evaluated and found to have a valvular heart problem and started on oral medications to be given twice daily continuously, a probable penicillin prophylaxis. Over the next 1 year, he had complaints of occasional dyspnea on exertion that was otherwise asymptomatic. The mother does not give a consistent history. Occasionally she says when he plays he has dyspnea, otherwise not specific. 10 months back, he developed complaints of edema of the lower limb and face. This was not associated with any complaints of chest pain or dyspnea, no abdominal distension or decreased urine output. Following this admission, he was started on additional medication that was given once daily for 5 days a week, probable digoxin. He was not started on any other anti-failure drugs along with this.
Where do you say digoxin probable?
5 days a week, sir, with 2 days off.
Is it recommended nowadays?
No, not, but she says any other medication.
It's no longer recommended as 5 days a week. Occasional dyspnea, is it common? It's going to be like when you have a certain amount of activity, the child gets into dyspnea.
She doesn't give a consistent history of dyspnea on exertion.
Again, that history has to be reassessed and retaken.
Over the past few months...
1 minute. What do you mean by occasional exertional dyspnea? What is the severity of dyspnea? Please explain the adjectives you use.
Exertional dyspnea.
What do you mean by occasional? What do you mean by exertional?
Exertion is occasional is a mistake on my part.
What is exertional?
Exertion is...
Suppose I climb to the 6th floor right now. If I get dyspnea, is it exertional dyspnea or not?
It is.
It is. So, what exertion brought about the dyspnea? Why is that important? Why is that important?
It grades dyspnea. You can grade.
Yeah. So, what is the grade of dyspnea?
He had
grade when you come.
He had grade 4.
What is the reason and rationale for grading dyspnea? Why should you do it? Is it just for theory class or for discussion?
It gives you an extent of his. You can grade his.
Anybody in the audience? Why should you grade it? Objectively follow up the severity. For example, a child who is having grade 1 dyspnea moves to grade 2, you know the disease is worsening and vice versa. Right? So objectively monitor the severity of symptoms. Right? How do you grade dyspnea? Do you use Objective methods?
This is more subtle.
How do you grade dyspnea?
Dyspnea, grade 1 is no dyspnea, and grade 2
No
is
dyspnea. Can a human being live without dyspnea at all?
What classification you use? Proper name you use? You have different classifications.
NIHA classification.
Which is the most easy and practical classification?
NIHA, New York.
Easy to remember 1, 2, 3, 4. 2 is ordinary, 1 is extraordinary, 3 is less than ordinary, 4 is at rest. This is the easy way. I don't know whether a specialist will approve, but this is for a generalist like me. Easy way. Grade 1, easy way to remember. Grade 2 is ordinary exertion. For example, Shruti climbing up 2 stairs from first floor to third floor is normal. She becomes dyspneic is abnormal. Right? Grade 1 is extraordinary. Me trying to go to 6th floor in a hurry. Yes, it's extraordinary. Very, very fast if I do it. Or I climb the hill. Footsteps at Tirumala hill. Extraordinary. Grade 3 is less than ordinary. For example, from here I move to the downstairs reception. If I get dyspnea, it is grade 3. Grade 4 is at rest. At rest. This is the most easy way to classify. Of course, there are maybe other classification. This is most easy. Because for every age you can always define what is ordinary. For example, ordinary for a young infant is breastfeeding. Ordinary for a school going child is to walk to the school or cycle slowly. So you can define based on the age. After all, it varies. So this is the easiest way. In what grade of dyspnea did this boy start with the symptoms?
Sir, he was already at grade
You said occasional exertional dyspnea. That's why I'm asking.
Grade, after playing for some time, he did like.
After playing for how much time? What
20
game?
minutes.
What game? It's very important.
Yeah, degree of exertion is class.
Yeah, what degree of exertion brought about the breathlessness?
Running around and playing with other boys. Then after some time he prefers
So
to
that
sit down.
becomes what?
Grade 1 severe exertion.
Grade 1 is extraordinary, ma. Grade 2. Grade 2. And what is the dyspnea now?
Now he's progressed to grade 3.
See, now it becomes important. So from grade 2 it has slowly progressed to
Grade 3.
Grade 3. Then other thing is, again you have to apply for dyspnea also the same chloride mnemonic. Whether it is persistent, how did it start, insidiously, all that is important. Please go ahead. Again I am repeating, please don't concentrate on what the mother has been doing with 5 days of medicine, orange color medicine, yellow color medicine. I think that's less important than describing what has happened to the chronology of events, right?
Over the past few months, he has been complaining of progressively increasing dyspnea, which is initially he would complain of dyspnea after running around and playing for around 15 to 20 minutes, which now he complains of dyspnea even on walking. He does not climb stairs because of dyspnea, but and it settles down after sitting down for some time. He does not have any complaints of dyspnea at rest or on lying down. No history of waking up from sleep with respiratory distress.
So anyone can become dyspneic on severe exertion. How do you differentiate that from a pathological dyspnea? And normally we run and we become dyspneic. We have a congestive cardiac failure, mild failure, we run and become dyspneic. How do you differentiate both? How long it takes to come back to normal? It's prolonged, it's going to be pathological.
2 months back, he developed complaints of joint pain in the right knee joint while walking to school. It involved only the right knee joint. It was not associated with any swelling or redness. He had no history of any preceding sore throat, fever or loose stools. No history of involvement of any other joints. He was able to sit in the toilet, walk around, but there was no limitation of movement, but he had a constant pain There was no associated rashes. For the above complaints, he was started on medications, and his joint pain subsided soon after.
Now, how long did the joint pain last?
2 days, 2 to 3 days.
Did it subside with medication, without medication?
With medications, it subsided within 2 to 3 days, is what she says. So it's more like a rheumatic knee involvement.
Go ahead.
Is it more likely a rheumatic involvement?
Yeah, and no history of any early morning stiffness also. So
No, what is typical of
rheumatic
arthralgia?
involvement, it subsides with NSAIDs. If you start medications, it subsides fast.
Is it a single joint?
Only a single. It is not migratory.
No, typical of a rheumatic. Is it a
Typical is migratory polyarthritis. It involves one joint for a week, for a few days, and then moves on to the other joint, and completely subsides in the first joint, involving the major joints, knee and ankle, elbow and wrist, and it subsides with NSAIDs.
But a single joint involvement is it taken as a typical?
It is a typical of rheumatic.
And nowadays with recent modification in the Jones criteria, even monoarthritis, no arthralgia, it's monoarthritis. It has to be inflamed in a high risk patient, typically in a Indian subcontinent. Monoarthritis, not arthralgia. You just put it as arthralgia. It's, even by your latest modification, it doesn't fit into rheumatic etiology.
So
it has to be arthritis. Arthritis is with inflammation. Arthralgia is without inflammation.
So
in fact, though Shruti said this is history of typical of rheumatic, I would say that this history is very, very inconsistent to the diagnosis of rheumatic fever.
Yes.
There are several things which are not fitting into rheumatic. One is that it is an arthralgia. Second is that it is a single joint. Third is that there has been no fever at all. Fourth is that there is no preceding sore throat. So with this history you can't say it is typical of rheumatic arthritis. Right?
So what is polyarthralgia you said? Polyarthralgia is included and monoarthritis is included. No monoarthralgia. Okay.
He has no other significant past history. Birth history is normal. He is well immunized for age. According to the Tamil Nadu government schedule, no other optional vaccines were given. BCG scar is present. Development, he studies in 5th class, has a good scholastic performance. He interacts well with his peers. No bowel and bladder abnormalities. Gets adequate sleep at night. Diet history, he has a calorie deficit of 1200 calories and 4 grams of protein. Family, he is second born to a 3rd degree consanguineous marriage. First child is a 13-year-old girl with no significant issues. There is no history of any cardiac complaints in the family. No history of any hypertension or diabetes mellitus. No history of any pox contact. Socio-economic history, parents are both 9th class passed, work as manual laborers. They stay in a 2-room Pakka house with poor toilet facility. They are a nuclear family, staying in 2 rooms, hence no overcrowding. They belong to the upper-lower class family according to Kuppuswamy scale.
What is the definition of overcrowding? You said there is no overcrowding. What is the definition of overcrowding? When do you say, for example, is this room overcrowded now?
Yes.
How do you define objectively overcrowding?
No people above the age of 7 years, brothers and sisters are supposed, even if siblings are supposed to sleep in different rooms.
Okay, 9 years.
9 years.
In the same room, 2 persons cannot remain in the above the age of 9 years. The WHO, that is what has defined. I believe for overcrowding there are definitions for European Union, for other countries, etc. But WHO says it is above 9 years, 2 persons, male or female, opposite sex or same sex, should not be staying in the same room. Of course, the room size also there again, I don't remember. Anybody remember the room size? I don't know. Not necessarily. More, Yeah, some criteria for the area is not. So why is overcrowding important? It's said to be epidemiologically important for spread of
Rheumatic.
streptococcal sore throat and important epidemiologically for your rheumatic fever.
And calorie deficient is nearly 1200 calories, but protein is just 4. Is it proportionate like? Carry on.
Which part of the history is deficient from the audience? She's completed. You have completed the history, isn't it?
Yes.
Yeah. Any deficiencies? Anything you would have done extra? Of course, she did present well. Anything else you would have done extra? Ishita, you also saw the case, no? Yeah. What is missing in the history? Pardon? One thing, remember, 2 things, of course she mentioned tablets being given. 3 things are missing. 1, what has happened to the schooling of this boy? He has a chronic disease. This is going on for quite some time. How has his lifestyle, schooling, day-to-day activities been affected by the disease? That is number 1. Number 2, is he growing well or not? Right? I never heard anything from Shruti about the weight gain of the child and about the height of the child. I mean, it's not necessary you must give kgs and centimeters, at least in comparison to other children. Number 3, the medications that the child has been on, and more so, in this child what medication particularly will be interested in knowing with regard to the prognosis of this child. How compliant are the parents with regard to the prophylaxis if the child is getting? 4, what is the diagnosis which has been made? What has the family understood about it? And the implications of the disease. All this is important. The history is incomplete if you don't mention. For example, with this disease, has he been going to school or not?
He's in 5th class.
5th class, what about school absenteeism? Even in asthma, school absenteeism is a very important criteria of severity and control. For that matter, any disease, adolescent boy.
I don't know. I mean, he studies in the same class appropriate for his age, but I did not
Number of
ask.
days absent,
I did not.
you should ask. Then of course, you should always ask about one more thing. Something to do with the growth of this child. Height, weight, then teeth, whether the child has had any dental problems. This is very, very important. Dental problems, and whether the child has had any recurrent episodes of pharyngitis. I think these points in the history would make it a complete presentation. Very important. Right? So can you sum up your history and tell me what this boy is having? Or shall I ask Ishita to do it? Ishita, can you sum up this history? Yes. Take the mic. Can you sum up the history, or you want more information? Either you sum up or tell me what is the list of problems from the history you have identified. Yeah. Whichever you want.
I'll tell the list.
Please tell me.
This is a 10-year-old boy. Well until...
Is that a problem?
No, sir. A chronic problem. Insidious in onset. Major symptom being exertional dyspnea, which is progressing. Though he is on some kind of treatment. And the problem is affecting his growth.
How do you know it's affecting his growth? She said 20 kg, so you heard her saying 20 kg, right?
So major symptoms being exertional dyspnea which is progressing in spite of treatment, and also joint involvement at one point of time, no significant past history, and
So that past history of that pulsations in the chest is not significant.
2 years of
Huh?
okay, I forgot a lot of points actually. Okay, so it started off as a visible pulsations, and then progressive dyspnea. In between there was a brief episode of joint pain and pedal edema. And the child is on treatment and apparently something which needs a long-term follow-up, also on some prophylaxis medications at regular intervals.
Shida, what is the primary problem in this child?
Cardiac, sir.
No. How do you know it's cardiac? What is the primary symptom in this child?
Exertional dyspnea.
What is causing this exertional dyspnea?
From the history.
What are the causes of dyspnea in general in a child who is 10 years old?
The causes can be divided into respiratory, cardiac, musculoskeletal, or central nervous system. So from
in this child, is it cardiac problem or a respiratory problem or a, as you said, CNS problem?
It looks more like a cardiac problem by
Why you say this is
by elimination.
By elimination, how did you
There is no cough, cold, there is no history of any past history of wheezing or anything suggesting of chronic lung disease or acute lung. Yes, it is present ever since it has occurred. It has never been well. So he's been there in interval.
I think all of you would agree that this is cardiac because it is primarily exertional. There is no cough, there is no noisy breathing, right? Definitely it fits into a cardiac dyspnea, isn't it? So if it is cardiac dyspnea, what is the cause, what is the cardiac problem that is causing the dyspnea?
It is more likely to be an acquired cardiac problem.
How do you know this is acquired?
Because he was apparently absolutely well till 8 years of age, both in
There are many cardiac diseases which can have symptoms starting from 8 years. Can you give some examples?
Cardiomyopathy, myocarditis.
No, I am saying, you said it is an acquired problem. I am saying this is not acquired. This is a congenital heart disease which has started manifesting from 8 years. Can you give please give me examples of congenital heart lesions which start causing manifestations maybe around 5 to 10 years. Examples I want. And this could be one of them.
ASD in the second decade.
Yeah. ASD, ostium secundum, may not be symptomatic at all in childhood, if not in the first 5 years. That is one classic example. What else? Name few other conditions where a congenital heart disease manifests with symptoms later in life. Sometimes even a PDA need not manifest. ASD, VSD, ASD as well as PDA need not always be. Of course, PDA is more likely to be symptomatic than ASD. PDA also the child could have no symptoms until even adolescence. That is the second. Anything else?
Cyanotic heart disease is something.
Which cyanotic heart disease will remain completely normal without cyanosis until 5 years, 8 years? And this is not cyanotic. This is an acyanotic. If at all this is a cardiac problem, this is an acyanotic problem. You don't know whether this is congenital or acquired. And the so-called pulsations had started without any history of suggestive of rheumatic fever, and some arthralgia had come. How sure are you this is not congenital? That is my question. Anybody else? Other congenital heart disease. That's what I want.
Mitral valve collapse.
MEP. The MEP, does it produce exertional dyspnea between 5 and 10 years? What is the commonest manifestation of MEP? Either it is palpitation or arrhythmia, or once you diagnose, they may become neurotics, cardiac neurotics. That's what will happen. Right? It doesn't cause dyspnea. Anything else? Congenital aortic stenosis, yes. Congenital aortic stenosis, pulmonary stenosis, all these mild pulmonary stenosis need not manifest in the first few years. Right? Anything else? Coarctation of aorta, infantile coarctation, it manifests very early. The coarctation of aorta may very well manifest even in an adolescent with intermittent claudication, headache, dyspnea, sudden hypertensive crisis, left ventricular failure, well known to present like that. Okay? So, very difficult to say with this history that this is not a
Congenital heart.
If at all this is a congenital heart disease, with this exertional dyspnea, what congenital heart disease will you suspect in this child?
Congenital MR.
Could well be a...
ASD.
You think this is ASD? This sort of exertional dyspnea alone occurring? Very unlikely. If at all you think of it, may be a coarctation manifesting like this. Right? PDA very unusual. Right? And there is history suggestive of cardiac failure, which is against aortic stenosis as well as pulmonary stenosis. Very unusual for a pulmonary stenosis present with cardiac failure so late. Right? Presents with either an angina type of chest pain or a dyspnea. So if it is not congenital heart disease, what are you left with?
Acquired heart disease.
Acquired. Which acquired heart disease this child having?
Possibilities are one is rheumatic heart disease. There is no history against points are there is no history of sore throat.
Does it rule out?
No, it does not rule out. 60%.
You can have indolent carditis.
50% of those who have rheumatic heart disease don't give history suggestive of rheumatic fever. Similarly, majority of children who have rheumatic fever may not have history suggestive of streptococcal pharyngitis. It may go unnoticed. So that doesn't rule out rheumatic. Any other possibility?
There is possibility of viral myocarditis or some form of cardiomyopathy, either congenital or acquired, which is...
The thing is, with viral myocarditis, usually the child should have started presenting acutely. The whole thing has been insidious. So it might not be, but it is not ruled out. It is not ruled out. Right? Anything else?
Kawasaki disease, suppose Kawasaki disease...
Kawasaki?
Unlikely, sir. There is... the presentation was not so severe. There is no chest pain. No past history of anything.
The last possibility is a multi-system disease with cardiac involvement. For example, you have a myopathy or a neurological disorder in which there is also a cardiomyopathy, Duchenne's and things like that, which is not there in this child.
Systemic hypertension can present with cardiac failure at this age group.
Shruti, what is your diagnosis at the end of this history?
Sir, 10-year-old boy, as far as...
No, don't sum up.
Probable sum up.
You agree that this is not likely to be a congenital heart disease, likely to be an acquired heart disease, likely to be a rheumatic heart disease. If it is rheumatic heart disease, what lesions are likely in this child? Do you think this child has got rheumatic fever right now, or do you think this child has got an established rheumatic heart disease right now?
I think it's an established heart disease.
Why do you think so?
He's been having a 2-year history of exertional dyspnea, so definitely there has to be an underlying structural abnormality.
If it is an established rheumatic heart disease, what lesions are likely?
So mitral involvement is MR is the most common in rheumatic, or MR plus MS.
What is the duration between the joint complaint and the cardiac complaint?
Minimum of 2 years.
No, in your case.
So the cardiac complaint came first. Probably I'm thinking the joint complaint is some recurrence of recurrence.
Does it have some implication? Your cardiac complaint and the arthritis, polyarthritis coming together, and your cardiac complaint coming after some time, does it have some implication on the type of lesion? When both comes simultaneously, it means rheumatic fever with carditis, so more likely to be mitral regurgitation. If it's going to take few years, it's going to be mitral stenosis. So the duration is going to give you some clue.
But since he started off as a probable cardiac without any history of rheumatic fever or any arthritis, we can call it, child presents as carditis only, carditis with
a cardiac complaint with a joint complaint.
So
that's what you mean?
No, initially he just had a cardiac complaint. He's saying increased pulsations, then went on to have the exertional dyspnea. His knee is only involved for the past 2 to 3 months, just 2 months. He had cardiac increased pulsations, then he went on to have the exertional dyspnea, had an episode of cardiac failure, all this over the past 2 years, and just 2 months back had complaints of knee pain. So he has had carditis with underlying heart disease and probable.
Has the symptom increased with your cardiac, joint complaint?
No, that he doesn't give a clear answer.
Okay. Not very informative.
I think this is where that history becomes important. How long is this child on penicillin prophylaxis?
2 years.
2 years. From the time the mother had noticed palpitation, this child is on
penicillin prophylaxis.
I think. Were they regular in prophylaxis? So in spite of that, something had occurred. That arthritis had occurred. One more question. If the same thing had occurred in a girl with this history, she is not on penicillin prophylaxis, this same history, what other differential diagnosis would it have?
Autoimmune disorders.
Again, SLE. Of course, male also can have. The last possibility is a vasculitis. The whole thing can occur. You can get myocarditis, you can get hypertension, renal, right? And the same story can occur. Right? One final question. Are you sure that this is rheumatic or non-rheumatic heart disease?
I'm not sure it's rheumatic.
What is the closest non-rheumatic heart disease which is related to streptococcus but which is not rheumatic? Anybody? Heart disease related to streptococcus but it is not rheumatic. What is that?
Infective endocarditis.
The so-called reactive post-streptococcal reactive arthritis, which was initially diagnosed in 70s and 80s, in the Western countries, they have reported non-rheumatic valvular disease in children diagnosed to have reactive arthritis, streptococcal reactive arthritis. Minority, but in fact, if you read the literature, they even nowadays have started recommending 1-year prophylaxis for children who have post-streptococcal reactive arthritis because of these cases. Okay? With this not even arthralgia, assume that this is monoarthritis, one of the differential diagnosis for this child would have been a post-streptococcal reactive arthritis. Post-streptococcal. The difference is post-streptococcal reactive arthritis, it does not typically cause the migratory arthritis. 1. 2. It doesn't respond to NSAIDs as well as rheumatic fever. 3. The ASO doesn't go up much, but the anti-DNAs might go up more. 4. CRP, ESR are not usually elevated. And last, they say epidemiologically, the latent period following streptococcal infection in post-streptococcal reactive arthritis is shorter than rheumatic fever. Rheumatic fever is about 2 to 3 weeks, whereas in post-streptococcal reactive arthritis it is 1 to 2 weeks, occurs faster. These are the differences quoted in the literature. If it is rheumatic, which are the valves which are likely to be affected in this child with this history?
Mitral and aortic.
Aortic also involved.
No, these are the most common. Mitral, I would say more.
Is this child having cardiac failure or not with this history?
Yes.
Why?
Had edema, increasing gestational.
Edema is there, exertional dyspnea is there, and from the history you found the mother noting pulsations indicating probable cardiomegaly. All this suggests that this child is having a cardiac failure. Right? Okay. Present the case. The child is cooperative?
Yes.
Can you get that?
And polyarthritis in reactive arthritis and post-streptococcal rheumatic, what is the difference in, like, is it more that is migratory, typical? How is this polyarthritis? Reactive. Reactive. It's additive. One joint gets affected. In typical migratory, that joint pain disappears and the other joint gets involved. Then that joint is asymptomatic and third joint comes. Here it's additive. First joint get affected. Next, after few days, first and second joint. After few days, first, second and third joint. It's more of additive. That is migratory.
But in the case of monoarthritis, then how we differentiate?
No, monoarthritis in a region with high risk region, it is taken as a criteria for this. There is a modification in the Jones criteria.
Suppose the child is not having polyarthritis, so we cannot say migratory non-migratory. Only is monoarthritis.
Monoarthritis is taken as a major criteria. 2015 guidelines.
No, it's a rheumatic arthritis or it is post-streptococcal.
No, that you can't make a difference. In the criteria, it's taken as a major criteria.
The differences, in the differences between rheumatic and non-rheumatic is not based on only one criteria, several things. Put everything together and then make a diagnosis. Sometimes it may be impossible to distinguish between post-streptococcal reactive arthritis and rheumatic fever. That's why I said, though the West has reported cases of cardiac lesions following reactive arthritis, they really don't know whether it is rheumatic fever or reactive arthritis which occurred in the past. Not possible always.
Yeah, how do you classify high risk area? More of a theory. High risk area and a low risk area. Incidence more than?
2 per 1 lakh.
Incidence of what? Incidence or prevalence? Incidence or prevalence? Fever more than? Per? 1 per 1000. But the prevalence of rheumatic heart disease more than 2 per 1 lakh. Incidence of rheumatic fever more than 1 per 1000, or the prevalence of rheumatic heart disease in the population. Incidence is in the school gauge group. Again the difference is there.
He is an alert child, poorly nourished, with no evident signs of respiratory distress. An examination, he has a muddy conjunctiva, no pallor or cyanosis, grade 1 clubbing in his upper limb, no edema either pedal or sacral, no significant lymphadenopathy.
How did you make out?
How did you make out grade 1 clubbing? I'll ask Dr. Ramasamban also to verify. What is grade 1 clubbing?
Obliteration of the angle. No, fluctuation.
Fluctuation only. Demonstrate fluctuation. No, that's not the way.
Keep like this, press here, automatically the other
Finger will
Move.
go up. That is fluctuations. Keep on, see there is a nail bed, no?
Yes.
Keep like this, like a butterfly, right? You press here and the nail will appear to float as if it is in a sea of water. It doesn't happen. There is no fluctuation.
So when you have clubbing, your whole scenario changes. You should bring in a history of infective endocarditis, things like that.
no dental caries. He has a bulging precordium with visible pulsations.
Why cyno-dental caries? Cyno, you use the term?
She said no cyanosis.
Oh.
He has a bulging precordium with visible pulsations and a flat abdomen. Vitals, pulse, 100 per minute in the right radial artery, regular rhythm, normal volume and character, no radiofemoral delay, no thickening of the vessel wall. All other peripheral pulses are well felt. Blood pressure was measured in all 4 limbs in the supine position. Right upper limb was 90 by 50 millimeters of mercury. Left
90 by?
50. 90 by 60.
90 by?
60, sir.
You said 50. You said 50 like your blood pressure went up in a moment to 60.
So 90 by 60.
I want your comment on the pulse volume. I want some volunteer. Vedita, tell me how the pulse volume is set. Normal, abnormal, low volume.
It's normal to high volume, if I would say. But
Sir, I thought it is very easily felt and slightly of large volume. Of course, maybe subjective. The reason why I caught Shruti was if it is 90 by 50, I would commit the volume appears to be slightly large. The brachials are very easily felt.
so if I say high volume, I will say it's not collapsing also. Do we add that also?
If it is,
Should a collapsing be high volume or pulse volume should be high to call it collapsing? Can it be low pulse pressure with collapsing? Okay. Can you have low pulse pressure with collapsing? Should the collapsing pulse be always associated with a high pulse pressure? So where do you get low pulse pressure? Pulse pressure is the difference between systolic and diastolic. No AS with AR. Once you get AR, it's a high pulse pressure situation. In MR and VSD, you can have a normal pulse pressure. Despite that, you can have a collapsing pulse.
So if I
olden days they used to use a term, not there in books, small collapsing pulse for MR and VSD. It's not technically correct, but I felt that the volume here is high, not collapsing, of course, right?
கால்ல கட்டி பார்த்தாங்களாமா?
temperature is afebrile.
Most often they don't tie the BP cuff in the lower limb, but they give a pressure lower limb BP. So examiner usually verifies whether the cuff was tied in the lower limb.
Okay.
So that time you get caught.
Saturation is 100% at room air in all 4 limbs. JVP is not raised. Anthropometry, his height is 130 centimeters and it is on
Where
the
was the
10th
lower limb cuff
in
tied?
the thigh above the population.
Was the same cuff used?
No, sir. A bigger cuff.
So make sure these technical details are followed. Carry on.
Height is 130 centimeters, which lies in the 10th centile. Weight is 20.5 kilos, which is less than 3rd centile for his age. His BMI is 12.13, which is less than the 3rd centile. All the following according to CDC charts. His upper limb to lower limb ratio is 62 centimeters to 68 and 68.
Upper limb to lower limb ratio.
Sorry, no. Upper segment to lower segment ratio is 62 to 68. His arm span is 120, which means it is which is less than the height. Cardiovascular examination. On inspection, his trachea is central. He's got a bulging precordium with a visible parasternal heave. His apex beat is visible in the 6th left intercostal space, lateral to the mid-clavicular line, involving a little more than one intercostal space. There are no visible pulsations in the suprasternal, neck or substernal.
There are no visible pulsation in the neck? Sirisha, come, please come. Mala nimdu nilra, nimdu nilpa, nilu. What is this? There are suprasternal pulsations in the right side. See here. You can actually feel it. It's a carotid pulsation.
No dilated veins.
Arterial pulsations are seen in the suprasternal region. Right.
No dilated veins, no scars or sinuses. Palpation, trachea is central. Apex beat is palpable in the 6th left intercostal space, 2 centimeters lateral to the mid-clavicular line. It is hyperdynamic in character. A thrill is palpable at the apex. A grade 3 parasternal heave is elicitable on the lateral sternal border. Auscultation.
No, this thrill is in.
At the apex, the mitral area.
So you didn't grade the murmur?
Palpation.
Okay.
On auscultation, mitral area, a loud S1 is loud. S1 is loud. A soft blowing pansystolic murmur, grade 4/6, is heard rest with the diaphragm in the left lateral position, and it is transmitted to the axilla and the back. A rough rumbling grade 3/6 mid-diastolic murmur is heard in the mitral area, rest heard with the bell in the left lateral position. In the tricuspid area, S1 and S2 are heard. A harsh blowing pansystolic murmur, grade 3/6, is heard, probably conducted from the mitral area. Pulmonary area, a loud P2 is heard, and a grade 3/6 soft.
You always related to inspiration, expiration. And it's not the same murmur, it's a different murmur.
Yes, sir, where?
Your apical and the lower.
Left sternal border.
It's a different murmur. Increases more with inspiration. Okay, you carry on. We'll just go on to the findings.
Pulmonary area, a loud P2 is heard. Grade 3/6, soft blowing ejection systolic murmur is heard. I don't know where it's best heard with the diaphragm. Aortic, both first and second aortic areas, S1, S2 sounds are heard, no murmurs. Perabdomen soft.
What is second aortic area? Given area called second aortic area?
Third left intercostal.
It's no more use. The term is not used. Should only say third, fourth space. Not accepted. Standard clinical books these days don't mention second aortic area. It's a misnomer.
But aortic events are heard in the third left intercostal space, because the aortic area comes like this, whereas pulmonary area comes like this. Mitral area is localized here. Mitral area is localized here. Tricuspid area is localized here. Whereas these two areas, there is an extension. Aortic, it's like this.
So I won't say second. Perabdomen soft, not distended. Liver is palpable 4 centimeters below the right costal margin. There is no spleen palpable. Respiratory system, no tracheal deviation. Precordial bulge is present with a visible parasternal heave and apex beat. Visible pulsations are noted in the suprasternal region. No dilated veins. Bilateral air entry is good. No basal crepitations or rhonchi. CNS, no neurological abnormality detected.
Abdomen?
soft, not distended, no free fluids, liver palpable, no spleen.
Liver how much?
Liver palpable 4 centimeters below the right costal margin, soft.
Always give the liver span.
I just
It can be a push down liver.
I had written it, but I forgot to push it.
And in any cardiac, more so with the congenital heart disease, you always mention liver is on the right and the tympanic resonant on the left. And also, how do you palpate the apex? Can you demonstrate how you palpate the apex? No, you palpate, don't ask them.
Where can I make him lie down? அம்மா இங்க உட்காருங்க. பாப்பா இங்க படு பாப்பா. படுடா. வா.
Even in sitting posture, you palpate the apex. Like, just wanted to see the procedure. No, this is what is not to be done. Okay. It can be dextrocardia. You are just concentrating on the left side. You always go like this.
Okay.
Localize the pulsation. Then you concentrate on the side where you.
Then fingers on the chest like this, so that you don't miss the dextrocardia.
Dextrocardia should not be mixed. More so with your congenital heart disease. Even a rheumatic heart disease can occur in a dextrocardia. So always first situs, then you go to the finding. So elaborate on the auscultation. Just highlight on each auscultatory finding.
Mitral area has a loud S2. I'm not sure. He has a loud heart sound, single heart with a pansystolic murmur.
You said loud S1.
If I will say it's a loud S1, I can collaborate it with the presence of a mitral big diastolic murmur. I can say there's a stenosis along with the regurgitation.
Is it a loud S1?
Opening.
Anyone else can auscultate and just comment on the heart sounds. The person who had seen it earlier, you had seen, no?
Can you say it's an S3? So loud, very loud. Backwards.
There are two findings in inspection which definitely arrest your attention. Can you tell me what findings which of course Shruti did not mention? Is this boy comfortable? Is this boy comfortable or is he having respiratory distress? How do you identify? How did you? Yes, definitely got significant intercostal retractions at rest. See, he is standing, can see the intercostal retractions, number one. Right? Number two, does he have a chest deformity or not? What chest deformity?
No, he's got a scoliosis.
Is his sternum projecting forward or not? What do you call that?
Rectus carinatum.
Okay? Of course, with an asymmetry of the left side of the chest. And one more finding, if you can lie down somewhere.
Did you mention the respiratory rate? How do you count the respiratory rate? Can you give a demo?
You make him lie down, stand at the foot of the wall and see his chest rise, or you can keep a palm on his chest and look for rise of your hand.
What is the procedure to see the respiratory rate? Just see the respiratory rate in this child. Count the respiratory rate in this child.
இங்க வா கொஞ்சம் ஸ்ட்ரைட்டா படு நேரா படு.
Okay. The thing is, you palpate and see the watch. You don't just see the abdomen and you can't be watching both your watch and your abdomen. You have to palpate, see the raise. I mean, you feel the raise and then have a watch on the. I mean, you look at the watch for 1 minute. Okay. So you see the respiratory rate. What is the heart rate here?
100 per minute.
Is it just 100? Can anyone of you just auscultate or tell me the heart rate here? The child is symptomatic at rest. Could it be 100? And what is the respiratory rate? And what is the implication? So heart rate you can count for 6 seconds.
So 6 or 15?
6 is,
Fine.
I mean, for your practical purpose, 6 is okay. 6 seconds, okay. Respiratory rate. Respiratory rate has to be counted for full minute. Keep discussing.
Basically, in an older child, you do not have to put your hand on the abdomen. You can observe. In an infant, it may be required, particularly if it is breathing fast.
Why hyperventilating?
Her respiratory rate is gone up. Relax. I thought there's a third heart sound.
There is a typical third heart sound, loud sound which you hear.
Failure, clear third heart sound is there. Second sound is loud, very closely split, and the pulmonary component is very loud. Right? There is a pansystolic and a mid-diastolic murmur in the apex, and there is a pulsation just below the xiphoid. Put your finger, pulsation. Yes or no? It's there, right?
And also there is a different murmur, TR murmur.
TR murmur.
TR murmur is also.
Yes.
So and S1 is not loud. A loud S1.
Changes it, yeah. It should be soft S1, yes. But I just heard one sound, I was not sure what it was. The loud
It virtually rules out a severe MR.
MR, yes sir. It should be soft S1
Soft S1.
in case of MR. Which is why I was not sure how the heart
Where can you get a loud S1 with severe MR? Another non-rheumatic papillary muscle dysfunction, things like that. Okay.
It's an acquired heart disease. Count, check for total counts. Check for any inflammation.
How do you interpret the complete blood count of this boy?
He can have anemia. He can have increased total counts. Increased
Right.
we can check the ESR and CRP to check for any.
What do you expect the ESR and CRP to be in this boy?
ESR should be raised anywhere between above 30 to 60.
In this boy, you expect a normal ESR or a raised ESR?
In this in this boy, unless you think of carditis, can have a normal dose.
What happens to ESR when there is anemia?
It's raised.
Increase. What happens to ESR when there is cardiac failure?
It falls.
False. So remember the fallacies, right? In a child who has got a cardiac failure, the ESR may not be very high. In general, CRP is more useful as a acute phase reactant even in rheumatic fever. Okay? It takes shorter time for it to go up and shorter time for it to come down. You are not affected by cardiac failure or by hemoglobin. So that's the advantage of CRP. What else will you do?
You can take a blood culture to rule out any infective endocarditis.
This boy, you want to do blood cultures?
No history of any fever.
So I don't think it is necessary unless the echo done by Dr. Nanasanam suggests that there are new vegetations. Otherwise, I don't think we need to do, or we document fever in MJ. We don't need to do a blood culture.
Chest X-ray to see cardiomegaly.
Before chest X-ray, suppose you want to prove that this is rheumatic fever.
Rising ASO titers.
ASO, what do you mean by rising ASO titer?
So, single ASO titer more than 330 is considered significant, but much more significant is a rising ASO titer across 4 weeks.
ASO titer is normal. Does it rule out rheumatic fever?
Anti-DNSB also.
Anti-DNSB. Do you do it here? You don't do. Anti-DNSB is, what is the difference between ASO and anti-DNSB? Anybody? The only difference is anti-DNase, the titer lasts for a longer time than ASO. Right? So, it doesn't make much of a difference. If both are positive, in fact, there is what is called streptozyme test which came to the market, now nobody does it. And there is very little reliance on ASO titer because it has got several false negatives and positive. For example, you do after about 6 weeks, ASO may not be high. And in a country where there is a lot of streptococcal pharyngitis, ASO can be elevated. That's why the cutoff is 320 in India, and other centers it may be lower. Depends on the endemicity of pharyngitis. Right? What else will you do?
ECG?
You do a throat swab culture for him?
Yes.
For this boy today?
No.
Suppose you suspect rheumatic fever, worthwhile doing to prove streptococcal infection. In fact, in the recent work, Dr. Gnanasanandam quoted, the circulation article in May 2015 has included even rapid tests as one of the evidences for preceding streptococcal. AP or PA?
PA. Three. Yes. This is last year itself, sir. This is 2014. No, this is 4th month. This is 3rd and 4th. This is 3rd month, this is 4th month, and this is 9th month.
Last year.
Any questions? Okay. Right. Thank you, Dr. Namaswamy. We want to have a final word. Finally, he has, I think, ECHO had shown that it is, I don't know.
Severe MR with the, ECHO had shown a rheumatic heart disease with a severe MR, severe TR with a PHT, moderate, normal LV function. He is on penicillin in VAS.
Thank you.
Thank you, sir.
You are a big hand, yeah? Normally she speaks loud. Today she was a little defensive.
Thank you.
Sir?